understand the recommended laboratory screening and referral criteria. And finally, we'll review some community resources that hopefully will be helpful to supporting your patients in reaching their goals. So much of the information that we'll cover is contained within Iowa Clinician's Guide to Prevention, Assessment, and Treatment of Childhood Obesity. This is a education handout that was developed last year by the Iowa chapter of the American Academy of Pediatrics Committee on Obesity, and it was modeled after work that's been done in several states. And we really brought together all of the most recent recommendations from the 2007 AAP Assessment and Treatment Guidelines, as well as the 2013 Prevention Guidelines. Additionally, in 2015, the Institute on Healthy Childhood Weight revised the algorithm. There's no big content changes. They just put it into an easier to understand format, and we have an adaptation of that contained in this guide. We reviewed the most recent specialty guidelines from the various specialty societies and incorporated all of the best practices from those. And we brought together Iowa pediatric subspecialists in all of the areas who are receiving obesity-related comorbidity referrals, and had them weigh in on all of the referral guidelines, as well as the information from all the society, specialty society guidelines. So the Iowa Medical Society and the Iowa chapter of the AAP Committee on Obesity, again, were the content organizers of this information, and then the Iowa Academy of Family Physicians, as well as the Iowa Department of Public Health, reviewed all of the content and endorsed the document. And so we have copies of these. If you haven't received it, when you signed up to be a 5210 registered healthcare clinic, you should have received these from Becca. If you have not received them or need additional copies, please send back an email and she'll be sure to get them in the mail to you. Additionally, they're online on the Iowa Medical Society website and able to be downloaded, as well as links to all of the resources and references are located right there as well. You can see the link for that page is on that document as well. So that's a great starting point. So we'll review all of the recommendations within that clinician's guide, but just some information about evidence for intervention. In 2017, the U.S. Preventive Services Task Force recommended that clinicians screen for obesity in children and adolescents and offer or refer them to comprehensive intensive behavioral interventions to promote improvements in weight status. And that research actually found that comprehensive intensive behavioral interventions with a total of 26 contact hours or more over a period of 2 to 12 months resulted in weight loss. And so they reviewed a lot of literature and found that the more contact hours there were, the more likely the children were to have changes in their body mass index. We know that body mass index is one result that we look for, but also something that a lot of the studies aren't capturing as well yet is the behavioral changes, and we know that those behavioral changes can have a big impact on decreasing the risk of comorbidities for these conditions. So the name of the game is to try and get families in more contact hours to be focusing on this issue. And we know that we can't do that in our clinic alone. So at the end of this lecture, we'll be talking about different community resources. And so the whole goal of that is connecting families to opportunities for increasing contact hours to focus on these healthy habits outside of our clinic to really augment the great work that we have on trying to get folks moving down this pathway. So on the first page of the Iowa Clinician's Guide, there's a nice overview of 8 things that we should be considering when we're starting to think about how we're going to prevent, assess, and treat childhood obesity. And so the first thing we need to make sure we're doing is assessing healthy eating and active living behaviors and the BMI. We'll talk more in depth about that. We'll share the preventive messages, and 5210 is endorsed by AAP as well as a number of other associations, and there's some great tools that we've already talked about available to do that. Furthermore, we'll plot the BMI on gender-specific and BMI for age charts to determine their percentile. We'll talk more specifically about BMI. And next we need to document and try and identify the children that are actually have an elevated BMI and are at risk for or currently have comorbidities. And so there's a lot in the literature about the number of kids that are out there who are ill with comorbidities, and we are not catching them. And so following these best practices really helps us identify those children who have already developed or are at high risk for developing these comorbidities. And so that's a lot of focus of the work that we'll be doing today. And to do this, we'll really need to take a good history and do a physical exam, thinking about obesity-specific components of each of those things, as well as measuring blood pressure and ordering appropriate lab testing, and then doing appropriate referrals. And there's some good tools within the guide to be able to give us some guidance in regard to that. Additionally, it's important that as we're doing this work, we're thinking about the impact of social determinants of health, as well as considering limitations and accommodations that may need to be made due to any disabilities that the children we're taking care of have, be they physical, intellectual, or cognitive. And then also addressing that special healthcare needs in some children may impact their ability to work towards their goals. And then, so just to let you know, there's we received a small grant from the Iowa chapter of the AAP to be able to do some of this work as far as developing a toolkit for children with intellectual and developmental disabilities. And so we'll keep you updated on the progress, but hopefully by this fall we'll have that up on the website, the 5210 Iowa Healthiest State Initiative website, as well as the IMS website, to be able to give you some additional tools to be able to help that population of children. And finally, as we talked about in a previous webinar, acknowledging the impact of weight stigma and bias in the clinical setting as we're embarking on this work. So let's start by talking about BMI and assessing healthy eating and active living behaviors in our patients. So one of the tables in the clinician's guide has this information on it. It talks about the different percentiles of BMI. We know in children that a certain BMI value is not what's used to classify them in different weight categories, but in fact it's their percentile on the BMI chart. So between the 5th and 85th is considered the healthiest weight. Between the 85th to 95th percentile is categorized as the overweight category. Between 95th to 99th percentile is classified as obesity, and greater than the 99th percentile is really that obese category with increased risk. And just the star underneath it reminds us that BMI depends on accurate height and weight measurements, and so that's why it's really important that we're following best practices when we're trying to weigh and measure children in our offices. And so again, there's a previous webinar that reviews best practices around how do we obtain an accurate BMI. And we know that it may be difficult to obtain accurate BMIs in some children with disabilities and special healthcare needs, and so there are some best practices to do that in that webinar as well as the toolkit. So we know that BMI is really a screening tool to identify health risks in some of our patients. We know that there's validity of this screening tool in children. It correlates with adiposity, and it correlates with adult adiposity. And furthermore, it correlates with cardiovascular risk factors and long-term mortality. And so there's some good data that BMI, even though it's difficult to get accurate weights and measures at times, if we're following those best practices, that it can be a very useful tool to be able to help identify risk for other health conditions in children. And so just to review, so we know that between the ages of 0 and 2, we should be using the WHO growth charts and reviewing the weight for length chart. And then once children are over 2, we shift over to the CDC growth charts and utilize the BMI growth charts. And so I think all of us have probably seen patients in our offices who have elevated BMI, so much so that it's difficult to track at a certain point if they're making progress and their BMI is going up or going down because of the limitations of the charts that we're using themselves. And so they've actually developed an extended BMI growth chart that's available. I know our EPIC system that we use at Unity Point has this available. We can click on the upper corner of our growth chart and be able to access this extended BMI growth chart. And this really allows us the opportunity to show families where their what progress they're making. And so it's helpful to be able to see, are they moving from that 160th percentile down to the 150th and actually making some progress that can really continue to motivate patients that they are moving in the right direction, and we weren't able to see that on previous growth charts. So just wanted to let you know that there is this extended BMI growth chart that can be effective when we're working with some of these patients. And so when we're talking about BMI and measurements, again, it's good to think about the importance of first doing no harm. So when we're embarking on these conversations of this sensitive topic, it's important that we're building rapport with our patients. We're asking permission to review growth charts. We're asking permission to discuss these topics as a sign of our respect for that patient's autonomy to make those decisions. And then that we're really meeting families and patients where they're at by listening what their concerns are, what their thoughts are before we're giving them our information, and then asking permission before we give the information to them. Again, we're avoiding confrontation, and we're trying to be gentle and empathetic in all of these conversations. And again, this is a good time when we're talking about BMI and measuring children to remember the weight bias that we've reviewed in the past. This is a slide from the weight bias webinar that we did. When we're talking about measuring children, again, it's important to focus on growth, both height and weight. We know that they're using some terms such as growth, weight, gaining weight more quickly than growing tall, or BMI, are much better received than using terms such as listed on the right-hand side, such as using the word obesity, since it definitely has some negative stigma attached to it, or any of the other terms that sometimes are used. And again, remember that weight bias is the belief that stigma and shame will help motivate patients to lose weight, and we know that that's just not correct, that it actually can put up more barriers to patients making progress and becoming healthier. Additionally, you can blame the patient rather than addressing many of the environmental conditions that we know also contribute to obesity. So we talked a little bit about BMI. We reviewed the importance of remembering weight bias and stigma and accurately weighing and measuring patients when we're trying to record those, and we reviewed the categories of obesity and overweight based on the percentile of BMI in children. The second part of assessing children is, I went the wrong way, is to assess their healthy eating and active living behaviors. And so that's one of the goals of the 5210 healthcare clinics, is to start consistently assessing children's healthy eating and active living behaviors. And the recommendation is to utilize the Healthy Habits questionnaire. And so again, this is it's a great questionnaire to be able to incorporate, to be able to gather information in an efficient manner and discuss it during the context of a clinic visit. So just wanted to review that. And again, remember that that's up at on the Healthy State Initiative 5210 Healthcare Resources webpage. And so when we're doing the assessment, we're remembering that as we're working through this process, we're asking permission to discuss the topic. We're sharing that information in an empathetic manner. And we're listening to families' concerns and thoughts about that information before moving on to the information that we're offering them about the link between BMI and their growth. And so we know that when we're having these conversations, that focusing solely on weight or where that child is on that BMI chart is sometimes difficult for families to understand and also to accept. And so really shifting that conversation from the focus on weight and BMI to the link between the growth chart and that child's health has been much better received by families. It really puts the focus where it should be, that we're trying to keep these kids healthy. It doesn't necessarily matter where they're on the growth chart, other than it increases their risk for comorbidities, which is the reason that we're focusing on BMI. And so making sure that families understand that there is a link between the growth chart and their health risks. So a lot of the conversations that we'll have in the office, we show them their growth chart, ask permission first, and then show them their growth chart, ask what their thoughts about the growth chart are, and then ask if it's okay if we share some information about how that growth chart relates to that child's health. And we know that if the BMI is elevated over that 95th percentile, it increases the risk that the child could develop type 2 diabetes, high blood pressure, high cholesterol, kidney and liver issues. So that conversation is usually really well received by families and starts to engage them in the process of making healthy behavior change to decrease those risks. And so in the assessment, and then also shifting off of that growth chart, and again shifting on to the healthy behaviors, that's a nice segue to branch onto the assessment tool and review how are they doing with healthy habits and how are they feeling about those habits. And this 15-minute office protocol gives you a nice framework to be able to work through those discussions using motivational interviewing and brief action planning during the context of a clinic visit. And so this is the chart in the Iowa Clinician's Guide that lays out the approach to childhood obesity prevention, treatment. And so we can see on the left-hand side that if the child's BMI is between the 5th and 85th percentile, then we work down this flow chart. So we positively reinforce healthy behaviors, assess their motivation and attitude towards behavior change. If they're having areas that they've identified that they want to make changes, trying to address these things before their BMI is in a less healthy range, is a great time to help them set small goals and engage that whole family in behavior change to really prevent childhood obesity. Again, if children's BMI is between the 85th and 95th percentile and they don't have additional risk factors, we all know those children with an elevated BMI and a really athletic build, so they've been tracking along the 95th percentile for their height and the 96th percentile for their weight. We know that those children are, and they don't have any other risk factors, they've got healthy habits started, we've not seen shifting across curves. Again, they can go down that pathway where we're assessing their healthy eating and active living behaviors and helping to partner with them on any behavior change that they're willing to engage on, and then reevaluating those families annually. And then moving on to the children in that 85th to 95th percentile, so they're in that overweight category with additional risk factors. These are the children that it's important to think about what are our next steps to be able to help those families and children. And again, those children with a BMI over the 95th percentile or definitely over the 99th percentile, all of those categories are good reasons to offer stage 1 and stage 2 interventions to partner with that family towards change. So again, this is for the 85th to 85th percentile and the 85th to 95th percentile without risk factors, kind of the format of what we should be doing in our office. But then when we talk about without risk, so what are we talking about when we're saying without risk factors? Let's review how do we determine the medical risk associated with obesity comorbidities, and what should we be thinking about there? So addressing medical risk, this really entails different components of our evaluation. So we need to focus on specific components of the medical history of that child themselves. Additionally, we need to focus on an augmented family history, augmented review of systems and physical exam, as well as laboratory evaluation. Let's start with history. So we know that some ethnicities, ethnic populations have increased risk of overweight or obesity that are listed there. So taking note of the impact of ethnicity. Also, kiddos with precocious puberty may be at increased risk for obesity as well. Medications associated with weight gain. I think many of us that have children in our offices taking medications or other medications that are well known to cause weight gain, and those definitely increase the risk and are of obesity, and we need to be cognizant of that. We know that children with a history of SGA or LGA are also at increased risk of obesity, and I think many of us have seen children in our clinic that are those NICU graduates or those children that are just growing along the bottom of that growth curve, and we're really increasing calories to try and keep their weight and their height velocity going in the right direction. And then all of a sudden, as they enter childhood, we'll see that something changes in their metabolism, and all of a sudden we're dealing with the opposite spectrum, and they'll shoot across a couple of percentiles on their weight while their height remains at the same lower percentile. And so being cognizant of those children that are SG or LGA from the get-go are more likely to have that pattern, so watching for that as we're seeing them at their annual visits. And then finally, understanding that children with disabilities are at increased risk of overweight or obesity, and making sure we're addressing and being inclusive in our efforts to help those children as well. So those are the components of the medical history that we need to be cognizant of when we're trying to figure out what is the medical risk. And then this is information about the family history. So the recommendations from guidelines are that we do an augmented family history or an obesity-specific family history. So making sure that we're paying attention to any family history of type 2 diabetes, high blood pressure, hyperlipidemia, elevated BMI in other family members, gestational diabetes, early death from heart disease or stroke, bariatric surgery, or the presence of non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. And then the other part of this is where will we document this? So I found that in the typical workflow of documenting family history, it doesn't necessarily flow directly into my note, and so I've started to add some of my family histories and negative, pertinent, positive family history into that problem list, or that can follow that child from visit to visit, so I can pull that information in more easily. But depending on your EMR, there are different workflows to be able to do that. So asking these questions and finding a way to be able to consistently document that so it's easy to evaluate at each of the visits is important. So beyond the history themselves and the family history, then we move on to what does an augmented or obesity-specific review of systems look like. So we know that there are a lot of comorbidities associated with obesity, and so screening for some of the symptoms of those comorbidities is important. So does that child snore? Is there any abdominal pain, menstrual irregularities, hip, knee, leg, or foot pain, signs of perhaps diabetes with frequent urination or excessive thirst, anxiety, school avoidance, social isolation, as well as severe or recurrent headaches such as problems with which you would see papilledema on the exam, or shortness of breath. And so this table in the Iowa Clinician's Guide kind of is a great review of all of the comorbidities, what signs and symptoms we should be looking for. As we talked about the polydipsia, type 2 diabetes, short stature or corridor, that will be found on our physical exam. And then the severe headaches, the pseudotuberous cerebri, is another symptom to be watching for as well. And so sometimes it's easiest to, so in our clinic we've incorporated a healthy habits review system. So if that child has a BMI greater than the 85th percentile, they get the healthy habits questionnaire, as every child does, no matter where they're at on the growth chart, but they'll also get this review of systems to make it easier to screen for those comorbidities more efficiently in the context of a clinic visit. So this has been really helpful in streamlining that process to consistently screen these children with a good obesity-specific review of systems. This format has also been helpful because the boxes allow patients to families, and they often will write a little bit more detail in there, which also helps to make the history gathering more efficient, I've found in my practice. And then moving on to the augmented or obesity-specific physical exam, we know we should be watching for a number of different things. So when we're looking at that growth chart, evaluating the BMI and weight velocity, and know that if the kids are crossing across percentiles, that's really an important thing to pay attention to. Focus on reviewing that healthy eating and active living, troubleshooting with the family. Are there changes that are going on, or what are their thoughts about the crossing the percentiles? But that's something we should be looking for when we're looking at our physical exam and reviewing those vital signs. Additionally, paying attention to if they're having short stature, and then reviewing their blood pressure as well, making sure that that's not elevated. And using the hypertension charts that are aligned for child's height percentile, so we know that those charts make it easier to figure out what is an appropriate blood pressure for children, and it is based on their height percentile. So on physical exam itself, looking for acanthosis, that nigricans, that darkening or thickening of the skin around the neck or in the axilla, looking for the presence of acne or abnormal hair growth in different locations or hirsutism, looking for inflammation or irritation of skin. We know that children with larger body habitus may have problems with yeast infections or other fungal infections and skin folds that we need to be cognizant of. Violaceous striae, which can be a sign of Cushing syndrome or other other hormonal problems. Papilledema, again, the pseudotumor cerebri. Tonsillar hypertrophy, as well as goiter, wheezing or abnormal gait, and limited hip range of motion. That abnormal gait or hip range of motion can be signs of problems with SCFE or split capital femoral epiphysis, which we know that children with overweight or obesity are at increased risk of. Bowing of the tibia or Blount's disease, as well as looking for signs of perhaps genetic conditions such as small hands and feet, polydactyly, or abnormal genitalia. All can be more common with children with genetic causes of obesity. So moving on to the laboratory evaluation. We know that it's recommended that children starting at between the ages of 9 and 11, even if their BMI is less than the 85th percentile, there are recommendations that we do obtain a non-fasting cholesterol level on these children. But if once children are over 10 years of age, if their BMI is between the 85th and 95th percentile, and they don't have any other risk factors, the recommendation is that we consider doing fasting lipid panel on them, not only the cholesterol, but also the HDL and triglycerides, as well as LDL. And then if they're over 10 years old and their BMI is in that overweight category and they have greater than 2 risk factors, the recommendation is that every 2 years we screen these children for comorbidities with a fasting lipid profile, fasting glucose, and then we consider an ALT or AST. And most recently, the National Gastroenterology Association recommended regular screening of children with obesity for non-alcoholic fatty liver disease with a ALT. And then if they're over the 95th percentile, and even at younger ages, so starting as young as 2 years of age, and there's some variation in the literature of when is the best time to start labs, doing lab work, but we know that we see lab abnormalities as young as children age 2 who have a BMI over the 95th percentile. And they recommend that every 2 years we do a fasting lipid profile, fasting glucose, and ALT and or AST, or an ALT at least, and perhaps an AST depending on what guidelines you read, as well as other tests indicated by history and physical exam, as we discussed previously. And so if we're doing lab screening, it's really helpful to have some guidelines on what to do with these results. If the fasting glucose is less than 100, again, we can fall back on that every 2 years screening recommendation. If they are in that pre-diabetic category between the 100 and 126, it's recommended that we provide counseling and recheck these children at least yearly. And then if they're over the 120, or if they're over 126 as far as their fasting glucose, that's a diagnosis of diabetes. We need to confirm that with repeat testing and then get them referred on to pediatric endocrine for further management. If that ALT falls between the 60 and 100 range, it's recommended that we recheck these in 2 months, and if it's still elevated, contacting gastroenterology for further workup. And if it's over 100, many of the gastroenterologists recommend a direct referral at that point. And then with the lipid panel, so if the fasting LDL is less than 110, we can repeat it every 2 years. If it's in that borderline range between 111 and 130, we're repeating it in a year. If it's more elevated, 130 to 160, recommend doing further evaluation with a more complete family history, and then also trying to initiate the child one diet and increasing their physical activity and rechecking this probably within 6 months. And if it's still elevated, or if there are other risk factors, considering referral to a pediatric lipid specialist. And if it's over 160, the recommendation is to get them involved in a pediatric lipid specialty clinic sooner than later. Additionally, looking at the fasting LDL, this is a common lab abnormality that I see when I'm screening children. Many times that LDL is low, that's the good cholesterol, and so providing routine care and rechecking every 2 years. So we want that LDL elevated over or above the 40, and then checking it more frequently if we see that weight gain is accelerating. And if it is low, the fasting HDL is low, that we increase the activity for that child and consider adding omega-3 fatty fats such as flax or fish oil, and then rechecking that again in a year. And moving on to the fasting triglycerides, if it's less than 100, if they're less than 10, or less than 130 if they're 10 to 19 years old, recommending routine care and then rechecking every couple of years. And then more quickly if that weight gain is accelerating. If it's in that middle range between 130 and 499, they recommend doing that omega-3 fish oil therapy in conjunction with the child one diet and rechecking in 6 months. And if it's persistently over 200, considering referral to the pediatric lipid specialist, and it's over 500, definitely considering that referral to the pediatric lipid specialist. And we know lipids are impacted not only by BMI, but also importantly so by genetics and family history, and so I'm making sure we're cognizant of that. But these labs, and in particular the lipids, we can often see changes. If kids increase their exercise and families increase their exercise and make some small changes in eating habits, we oftentimes can see within 6 months to a year improvement in HDL. Exercise really drives that HDL up into a healthier range, and the triglycerides can be improved significantly as well. And also when we see kids with an elevated HDL and triglyceride, or with a low HDL and an elevated triglyceride level, those children also make us think of, are probably the children that are increased risk of the type 2 diabetes. There's some linkage between those lab abnormality patterns. And so making sure we're screening that glucose and watching for those other signs of insulin resistance on physical exam consistently. So the problem with labs that often comes up is how do we get labs paid for? And so CMS or Medicaid guidelines state that we should be able to use a diagnosis of obesity as a reason for ordering a lipid panel, for ordering a glucose and abnormal weight gain as a billable diagnosis. And then for the ALT, I often link it to obesity or abnormal weight gain. There aren't specific guidelines around that lab, and so I haven't had problems with that Medicaid population getting that covered by linking it to both of those. Additionally, we've done some work with the Iowa AAP Committee on Obesity, and we've had inquiries to private insurers such as Walmart about their coverage of obesity-specific follow-up visits and lab evaluation, and have been told that those are billable diagnoses, as we've listed for the Medicaid population, for their insurance as well. But it's difficult to obtain information and billing information about what is being denied consistently across the state. And so I just ask that if you're doing lab evaluations or you're struggling with denials from insurances, please forward that information, if you will, on to me, and then we can work on that at the state chapter level on our Committee on Obesity and advocating more broadly for this issue to make sure that coverage is consistently available for these important lab evaluations for these children to screen for these comorbidities. So those are all of the things that we need to consider when we're looking for a medical risk. So we're looking at those specific points in that family, in that personal medical history. We're looking at the family history. We're looking at specific points on that review of systems as well as that physical exam. And then finally, we're doing that laboratory evaluation to really get a big picture beyond that BMI, what other components of that child physical exam and exam are increasing their medical risk. And so taking all of that information together then allows us to move into stage management. So what do we do if we identify the child as at increased risk, has some comorbidities already, or is at definite risk of it? And the recommendations are that we offer within our primary care setting stage 1 and stage 2 management. And so it can be, at first glance, it can be overwhelming and to think about how do I really partner with these families on an ongoing basis to help them avoid some of those comorbidities or decrease some of the consequences of the comorbidities. And so in the clinician's guide, there's this outline of what is stage 1 and stage 2 management. And so stage 1, also referred to as prevention plus, is really meant to be done in a primary care office. The 15-minute protocol, between 15 and 25 minutes, I think you can easily address this in your office setting. It's important to utilize whatever resources you have available. And I think that stage 1 and stage 2 can look very different in different clinic settings, depending on what strengths and opportunities that you have. So in some settings, this is being offered with the use of a nurse care coordinator who's helping to add increased contact hours with these families. So it's not necessarily with the provider themselves, but with the care coordinator to add support and counseling. Some clinics use a wellness coach or a health coach that they may have available. Sometimes there's an opportunity to partner with a physical therapist in the community or in your office, or trained nursing staff who have an interest and passion in this area. Can they partner and follow up more frequently with the families, or dietitians? And again, there's challenges with reimbursement for these services. Many of these services are not covered, but in these new models of payment, sometimes there are opportunities to find streams of revenue that can help support having these additional support services available for your patients. But really, even if you don't have any of those resources, there are opportunities to offer stage 1 and stage 2 within your clinic. It's really important that you're remembering that we're tailoring this to the family's motivation, utilizing that brief action planning, motivational interviewing styles we talked about in the last webinar. The recommendation is that we try and strive for monthly contact with these families. So is there a possibility that we can correspond with that patient? Maybe the nurse sends them a message through their portal, patient portal, or maybe it's a phone call if they're interested in following up that way on a monthly basis. And then having a follow-up with that primary care provider in the office, and that is a billable office visit to be able to have that touch point. In my experience doing this with families, every time we shift to a different, and they have to get to know somebody else, they have to get to know the care coordinator or the wellness coach, sometimes that can be a difficult barrier, just that connection or that linkage to someone else. So they may not be following up with that wellness coach at those monthly, but they'll show up for that 3-month or that 6-month visit with me because of the relationship that we've established. And I think that's pretty consistent, that probably the strongest patient relationship that patient has with somebody in your office is with the provider themselves. And so I think that making sure that we're offering this to families. So it's their decision whether or not they want to move down this pathway. Our obligation is to offer that opportunity to them, to be there to partner with them, and then they get to make that decision of whether they're ready for that or not at this point. And we can help them along that process with the motivational interviewing if they're not sure if they're ready for change or if they are, moving them towards those goals. And I think the thing that really helps to decrease your no-show rate is to offer that to the families and make sure that they are making that decision and they're not feeling pressured by my wanting them to make changes. If they're ready for change, asking, would you be interested in following up in 3 or 6 months to see where we're at on the growth chart and reevaluate how we're doing with the goals that you're interested in making? Or would you rather follow up in another year, giving them that opportunity that if they're really not ready for change, that they're able to say that, and that will decrease your no-show rate, and then offer more time for you to really focus on this intervention for families that are ready for it, and the no-show rates will be lower. And so when we're having these more frequent contacts, we're utilizing whatever resources we have available to increase the number of contact hours. We're offering to see them back in 3 or 6 months. What are we really looking for when they come back? And the main thing that we're looking for is positive behavior change. That's where utilizing that standard healthy habits assessment is really helpful, because you have something to focus on beyond that growth chart, because we know that all of those behavior change make a big influence on decreasing the risk for comorbidities. So we're looking for positive behavior change when we're comparing one of the responses on healthy habits to the previous visit. Additionally, we're looking for weight maintenance. So children have the opportunity to decrease their weight velocity, so they don't necessarily need to lose weight. They're still growing taller, so they can grow into their weight, or level off or decrease the rate of rise of their weight, or decrease their BMI velocity. So many times in that stage 1, we're not necessarily looking for them to lose weight, but more so decrease their BMI velocity, how quickly it's growing further, flatten that curve on their growth chart, or maintain their weight. And then again, our goal is also to increase those contact hours by connecting them to community resources. And so we'll go through some of those here at the end of the discussion as well. And hopefully you'll find something that will work for some of your patients. So again, we're using that 15-minute protocol. We're partnering with families, offering to see them at 3 months and 6 months to follow up on how they're doing with their goals. We're utilizing whatever resources we have in our clinic, and then connecting them with the resources in our community. And then after 3 to 6 months, we review and see how things are going. Have they made improvements in behavior change, or have we seen any stabilization in their BMI or weight velocities? And if not, then the recommendation is that we advance to stage 2, or offer to families the opportunity to contact and meet with them more frequently, and offer them more support. So this is stage 2 is also called structured weight management. Again, it's meant to be done within the primary care office with some support. So again, looking at what other opportunities you have to partner with dietitians in your community, physical therapists, wellness coaches, all of those folks we mentioned above, but trying to facilitate that linkage with those other professionals that can help support the family in their goals. Again, you're tailoring it to family motivation and offering more frequent contact. So are they interested in working with that care coordinator and touching base with them by email weekly or monthly, and then following up, not necessarily in that 3 to 6 months, but more of that 3-month range, to partner with the provider and review and do continued goal setting. Again, we're looking for the same outcomes as above: positive behavior change, weight maintenance, or decreased BMI velocity, and we're looking to connect families to resources. And then if there's no improvement or stabilization after another 3 to 6 months, then the recommendation is that we move forward into stage 3 or stage 4. And so the focus of this webinar today is on stage 1 and stage 2. What can we be doing in our primary care offices to help set patients up for success, partner with them? Because for some families, stage 1 or stage 2 is all that they need. We'll see improvement with those families if we give them that opportunity to partner with us and to make some goals. But for some children, they'll still struggle. And so we know that there aren't a lot of places to refer kids. There's not a lot of stage 3 or stage 4 clinics in our state. We're working at the Iowa Chapter Committee on Obesity to develop a one-page handout of all of the resources that are available. There are some small sites that are doing more structured stage 3 supported clinics, and stage 4 as well. And so, but we know that for any of those to be successful, the idea is that we need to connect motivated families with the resources that they need. And so sometimes without stage 1 and stage 2, it's really easy for stage 3 and stage 4 clinics to become quickly not financially stable. So the no-show rate can be high if we're referring families that aren't ready for that. We can actually put up more walls to change if they're not ready to take those steps and feel pressured into it. And so really doing our part in primary care to support those families, recognize what they're ready for, and then when they are ready, being aware of what community resources may help them, and then getting them into stage 3 and stage 4 clinics when they're at that point and ready to take that next step. So we've talked about this a lot already, remembering it's the patient and family that's really dictating the rate of progress. They may not be ready for change, and if they're not, there are things that we should do. We shouldn't label them as they're not ready for change. That readiness for change is fluid, so they may not be ready for change right now because they've got a lot on their plate at home. But the next time we come in, being able to have that respectful conversation, reevaluate whether they're ready to make steps. And you'll be surprised that many times things have changed and they are ready to make some improvements. And if we're using that motivational interviewing, being respectful in those conversations, we're setting the stage for future visits, even if at this point they're not quite at that point for moving down the pathway towards change. And again, utilizing that brief action planning to make it an efficient visit in your clinic, and then asking if you can follow up. So even if they're not ready for change, ask if they'd like to come back, or offering the opportunity to give you a call if they are ready for change prior to that next visit. Again, when we're focusing on outcomes for this stage 1 and stage 2, it's really important that we're focusing on our concern for their health, not only on that growth chart, and that's easy. And even when we're scheduling these appointments, it's important to recognize weight bias and stigma that we may be contributing to. And so in our clinic, we really focus on it's a growth recheck, not necessarily a weight recheck. So we're looking at how they're growing as a child overall. Some clinics call it a healthy habits recheck, so they're really focusing on those healthy habits and not on the growth chart as much at all. Acknowledging that it's very difficult in our current environment to make lifestyle changes and provide support along that pathway. And then also recognizing that small weight losses or behavior changes can result in significant health gains. So we know that in the adult population, for many patients, it's really difficult if their BMI falls within that elevated range to move that BMI out of that range. But we know 10% weight loss, even though they're still in that increased risk zone, that alone can decrease diabetes risk in those populations. So focusing on behavior change and small gains as being important for health gains. And again, like we talked about, we're focusing on stabilizing weight gain and also weight loss, behavior change and healthier habits, and improved labs. That's something that also can be really motivating to families. So can we maintain that glucose out of that diabetes range? Can we decrease it from that pre-diabetes into that normal range again? Making sure we're acknowledging that ALT and making improvements to keep that in a healthier range, as well as improving that HDL and triglyceride levels. So again, this is just a review of that 15-minute obesity protocol, where we're assessing, like we talked about at the beginning, we're agenda setting, so we're acknowledging and focusing on their readiness for change, and then setting small goals if they're ready. We're assessing their confidence, and we talked a lot about that last time. Kara, I think that somebody's line hung up, so we may need to mute that. Can you hear me okay? Sorry about that. Okay. All right, I think we're good. So, and then finally assessing confidence, and then we're scheduling and summarizing, scheduling follow-up with them. All right. And so I just wanted to let you know about another toolkit that's going to be available. This is the Healthy Habits Toolkit. It's really focused on giving you tools to support stage 1 and stage 2 management. So there's 9 different topics about a lot of different things that children and families might be interested in making goals around. It gives you a great one-pager, and then also a guide to help efficiently work through a clinic visit in a 15 to 20-minute time frame. This is what the handouts look like. They'll be up on the website here in another month or so. They have a handout for the patients as well as a guide for you to kind of work through that visit in your office. And then how do we code and bill for this type of a visit? So we can bill based on time spent with a 99213 or 99214. The billable diagnoses include obesity, or often if they're in that overweight category and have comorbidities or risk factors, I'll make sure I document those first and have not had problems with reimbursement for this. And then if you're in Unity Point, we've developed a dot phrase, .5210 BMI time, either the 15 or 25. And then the scripting for that it populates into your note is the time spent assessment or attestation that is necessary for billing. And so you can often cut and paste this into your own EHR to make it easier to document this. And then as far as the note templates, so really, how do we streamline this? How do we take one portion of this at a time to incorporate this into our workflows in the office? And so there is a dot phrase that we've developed for doing a follow-up growth check. It pulls in their previous goals as well as their previous healthy habits questionnaire results and previous labs. And then it has the opportunity to document that augmented family history review systems and physical examination as well as the time attestation. And then there's an easy way to pull in the new goals and follow-up plans that you set during that visit. But really, finding ways to streamline this process in your EHR is what makes it really possible to incorporate stage 1 and stage 2 into your daily visits or into your daily practice. The other thing is that sometimes approaching this through a quality improvement process really is helpful in breaking it down and doing small steps and tests of change to make changes into the way we do things. And so there's a project called Childhood Obesity and Primary Care that's sponsored through the Institute on Healthy Childhood Weight. And over the last 3 years, we've had a number of practices across the state that have been participating in this. And this year, they also allowed family practice clinics to participate. And so the intent is that they'll have this on an annual basis. And so if you're interested, let Becca or I know, and we can get you hooked up when they open the enrollment process for next year. And I want to end with community resources. We've got about 7 more minutes, so I'll go through these fairly quickly. I wanted to start with community resources, so finding out what opportunities there are for kids to be active at your schools. This is a website that links to the Iowa Department of Education, and it has all of the information about nutrition and physical activity opportunities in the schools, as well as the wellness policies. And so this is an opportunity to become familiar with what opportunities there are in your schools for kids to be more physically active or follow those best practices around nutrition. Many schools offer before and after or during school programs, such as Kids Striders. Kids Striders is an organization where they have a running club. Kids earn tokens or medallions for the number of laps run, and then if they run a number of laps, then they get to participate in the Grand Blue Mile, which is actually this afternoon downtown here in Des Moines. And so it's a great opportunity. And there are many similar programs, mileage clubs that get kids excited about moving and being active during that time that they have at school. Also looking at your recreation opportunities in your community. So many communities have YMCAs or recreation departments that have special programming for kids. So making sure you're aware of what opportunities are available in your community and referring families who are interested in setting goals around physical activity to some of these great resources is another way to increase their contact hours when they're making behavior changes. Just wanted to mention a program called Healthy Weight in Your Child. There aren't a lot of sites in Iowa that are utilizing this program yet, but there's a lot of great evidence behind it. It's very similar to the diabetes prevention or the DPP program, which is more widely available throughout the state. And so it's a child version of that. And I mentioned it once, so you're familiar with it. It's based on men, and so there's a lot of great evidence that this is effective. It does take a very motivated child and family, and so that's where our assessing their readiness for change and being able to give them information about these opportunities when they're ready is really important to the success of that child as well as the success of the program we're referring to. But just keep your eye out for opportunities for DPP, because if you've got a family that can get involved, there's great resources for the family. We know that any health behavior changes that families as a whole are making are going to have a positive impact on that child. And then know that the YMCA, there is a program that has some great evidence. So if you have recreation centers in your community that are looking for programming ideas, this is a great model to base what they're doing off of. Many communities now have Growth on the Run, and there's an analogous program for boys. I think it's called Stride or Let Them Run. And these are great programs that really help kids who may not be really the kids that enjoy competition or team sports, but allows them opportunities for physical activity and self-esteem building and camaraderie without that necessarily competition aspect. And so great movement on a lot of new programs across the state for this, so look for that in your communities. Most communities have park and rec departments with great resources to get families and children active, so being familiar with the resources and linkages to those opportunities in your community is really helpful for many families. And then moving on to extension. So there's a program across the state called Buy, Eat, Live Healthy, and so it has some other acronyms for it as well. But basically it's a program that can be taught in families' homes or in small groups in public settings, and it's once a week for about 8 lessons. Families commit to working towards attending all 8 lessons, but they focus on getting moving, planning, shopping and saving money, focusing on how to get kids and families to eat fruits and vegetables, as well as information about whole grains and healthy eating with protein and calcium-containing foods, as well as some exercise. They actually have a lesson on exercise as well. I think they've incorporated one more activity into one of these lessons as well. So this is a great program if you've got families that are interested. There's some contact information, and you can reach out to your local extension to see the availability of this program in your communities. They also have an opportunity for you to fax a referral. So if the family is interested and they want to fill out that referral form and then your office can fax them, that sometimes helps to bridge that gap between the office and this community resource. Again, it's important that families are motivated and are ready for this kind of commitment, but if they're ready, it's really helpful for a lot of families. They also have an app that's a free download, and it's called Spend Smart, Eat Smart. And so this has great information about cooking, recipes, fruits and veggies, how to be cost conscious when you're shopping for fruits and vegetables and other foods, and so it has a great unit calculator. So great resources to get families and kids information right there at their fingertips. Then I just want to mention a few online resources. There's Hy-Vee Kids Fit that's doing some great work. They actually have a 5-week challenge, which is a booklet that can be downloaded, or some local Hy-Vees are printing them depending on your community. And they've incorporated goal-setting components to this challenge where kids write small goals and follow up. They've got some good education, and they've focused around the 5210 message, so it corresponds nicely to the messages we're putting out in our clinics. And so you can check into that as well, check with your local Hy-Vee. Some of them are offering prizes in the stores if they complete it, but it's a great thing for kids and families to do together over the summer. Additionally, there's the Dr. Young Project. There's a lot of disconnect, and many young people and families don't necessarily have a lot of skill around planning meals or cooking, and so this is a great resource to get kids and families excited and give them some tools to increase their cooking skills, which we know is so important to staying healthy. Go Noodle is another online resource that many schools utilize for brain breaks during activities, during classroom activities, and this is great in cold Iowa winters that kids can do a few of these Go Noodle videos. They're free online. You can use them at home after dinner or before dinner to keep kids busy, but the younger elementary school kids really enjoy this website. And finally, First Five. First Five is important for connecting our families to other resources in the community, but they've also done a nice series of nutritional videos, picky eating, kids who are picky eaters, growth charts, and the 5 W's of raising a healthy eater. So these are all YouTube videos that are targeted towards families. They're, I think, between 4 and 7 minutes and do a really nice job of explaining some tough topics and giving families really practical advice on how to make changes. Just to review, we've talked about the components of Stage 1 and Stage 2, and hopefully giving you some practical tools to facilitate gathering and documenting obesity-specific family history review systems and physical exam. We've reviewed the laboratory screening recommendations, as well as some practical ways to implement this into your practice.